Hello, well, welcome back to day 4 of the course, and this day looks at chapter 4, and it deals with the new roles and responsibility of the new bodies and players in the NHS. The GP Consortia will work with other care professionals and will work in partnership with local communities and local authorities, and will commission the great majority of services for their patients and will be influential in driving up standards. Every GP practice will have a member of the consortium, so they'll each have a member that will belong to the consortium. Practice will have flexibility to form consortium in ways that they think will secure the best healthcare and best outcomes for their patients and locality. The consortium will have responsibility for commissioning services for people who are not registered with GP and commission services with local authorities. In order for this work to work effectively, the consortium needs to be of sufficient size. GP Consortium will have the freedom to decide what commissioning activities they undertake from themselves and what they will buy in from either the local authority or private sector or the voluntary sector. Consortium will have a duty to promote equalities and to work in partnership with adult social care, early years service and public health which will be situated in local authorities, and safeguarding. They will also have a duty to the public and patient. They will also have a duty of public and patient involvement, and the need to engage the patient and the public in neighbourhoods in the commissioning process. Healthwatch will provide information about the needs and aspirations of the local communities. So I'm going to go on to some of the duties of each of the big players, and the role of the NHS Commissioning Board, which is a national board. And there's 5 main functions. Number 1 is to provide national leadership for quality improvement, setting commissioning guidelines on the basis of clinically approved quality standards developed with NICE, and designing model contracts, designing the structure of tariffs, hosting some clinical commissioning networks such as rarer cancers, setting standards for quality of NHS commissioning and procurement, making available accessible information on commissioning performance. Number 2 is promoting and extending public and patient involvement, championing greater public involvement in decision making and managing their care, promoting personalisation and extending patient choice, commissioning information requirements for choice. Number 3, ensuring the development of GP commissioning consortia, developing their development, holding them to account for delivering outcomes and financial performance. Number 4 is commissioning certain services that cannot solely be commissioned by the consortium, such as GP dentistry, community pharmacy and primary ophthalmic services, national specialist services and maternity services. Number 5 is allocating and accounting for NHS resources. Key to this is promoting productivity through better commissioning. Now, it details the the white paper details the role of the Secretary of State, because that has changed somewhat. And the powers are going to be limited to setting a formal mandate for the NHS Commissioning Board, holding the NHS Commissioning to account, have an arbitration role, for instance, between NHS commissioners and local authorities, the legislative and policy framework determining the service the NHS provides, publishing national strategies and accounting annually to Parliament. So they have much more of an overseeing role than previously, where it's a bit more hands-on. PCTs will be abolished as they no longer have a commissioning role, and public health will move to local authorities. And directors of public health will be jointly appointed by local authorities and the Public Health Service. Local authorities will have the power to promote well-being, and health and well-being boards will be established. These boards will be with local authorities and will take a strategic approach to promote integration across health, adult social care, children's services and the wider local authority agenda. Local authorities will have power over and influence over the NHS in their area and will be able to influence what happens within, will be influence what happens locally. But they each, both the local authority and the NHS, will be expected to have much more integrated services, particularly when it comes to mental health and the elderly. Local government's new functions will be promoting integration and partnership working between NHS, social care, public health and other local services that have a health input. They will lead on the joint strategic needs assessment, and they will build partnerships for service change and set priorities. Local Health Watch will be part of the local authority and will feed into the local authority services and that of the NHS. The next part is called freeing existing providers, and this is quite a big statement, but it says the ambition is to create the largest social enterprise sector in the world. And this will provide services to patients and will be able to adapt to local need, whether it's from the private or the voluntary sector. Foundations trusts will change, abolishing the cap on the amount of income that they may earn, allowing them to reinvest in other services and allowing them a much broader scope, for example, to provide both social care services and health. And it will enable foundations trusts to merge more easily, and they will be expected that within 3 years all NHS trusts will be foundation trusts and all community services will be provided by that foundation trusts. All this change will give patients greater choice and create a competition in the market, and it was hoped that it will stimulate innovation. The role of the Care Quality Commission and Monitor will be enhanced, and they will both operate a joint licensing system. Trusts will have a joint licence agreement where trusts fail to meet standards, then providers will be subject to enforcement action, including the possibility of fines and suspension of services. The Care Quality Commission will inspect providers against essential levels of safety and quality. Monitor, who will be doing the finance function, has 3 key functions. It will promote competition, and it will make sure that there's no anti-competitive behaviour. It will regulate pricing to set efficient prices, promote fair competition and drive productivity. This will be done in consultation with the NHS Commissioning Board. It will support the continuity of services, ensuring continued access to key services and defining regulated services which are subject to special licensing conditions and controls. The powers will include protect assets or facilities that are required to maintain continuity of service, authorising special funding arrangements for essential services that otherwise would be unviable, a power to put a levy on providers for contributions to a risk pool. So if there was any sort of problem with trusts overspending, there is a risk pool that they can then draw on. They will intervene directly in the event of failure, including the power to trigger a special administration and regime. Now, there's a little bit in the white paper about valuing staff, and what it says is that they will continue the implementation of Dr. Steve Boreham's review, which looked at the NHS being a beacon for healthy workplaces, and that work should continue. Now, training and development is also mentioned here, but I think it's fair to say that this part of the white paper was quite unclear, and that was picked up in the consultation. However, the professional bodies will still have a big say in the shape of training being offered to clinical staff. It is clear that all healthcare services will have to pay to meet the cost of education and training. Transparent funding flows will support a level playing field for providers. I think it's always been a bit complicated how this has been done, and I don't think the white paper clearly sets out how it will be done, but nevertheless, that's their aim. The NHS Commissioning Board will provide oversight of healthcare providers, making sure that they fit with the strategic intentions. The Centre for Workforce Intelligence will also provide a source and analysis, a source for both information and analysis in informing all levels of to the system. NHS pay, now traditionally that's been set by the Department of Health, but now, like all foundation trusts, the white paper will say that it's going to be decided by healthcare providers, and they will set the pay for their own staff. There's a general trend away from centralisation towards decentralisation. NHS pensions, in line with other changes in the public sector pensions, obviously there's a big debate about that at the moment. Okay, so we've got a few questions for today. You don't actually have to answer them all, but it'd be good if you can just consider some of them. How do you feel that the GP consortium and their ability to commission will change your role? Do you think it will change the way that services are provided? In creating the NHS commissioning boards and reducing the Department of Health's involvement, this may reduce bureaucracy, enable the NHS to innovate more freely. What do you think are the disadvantages to it? And I think with any advantage, there's always disadvantages, so it might be worth considering those. What do you feel the effect will be in moving public health to local authorities? How effective has public health been in the PCT, for instance? Do you think that you could end up working for a social enterprise? And what do you feel about this? Creating new roles for the Care Quality Commission, do you think that will really reduce some of the recent tragedies, such as the ones in Staffordshire and others that have made the news? What do you think? Do you think this will really help it? So they're just some of the questions for today. If you can answer just some of those, that would be great. Thanks.